This video will talk about hypertension, which is a very commonly asked question and a very commonly occurring condition. So hypertension. Hypertension is a condition in which arterial blood pressure is elevated. Now, there is a classification based on how do you classify hypertension and to what levels of blood pressure. So, first of all, category, then systolic blood pressure, and then diastolic blood pressure. Now, normal is less than 120 and less than 80 mm of Hg. Pre-hypertensive is 120 to 139, 80 to 89. Now in hypertension 2 you have a stage 1 which is 140 to 159 and 90 to 99, and stage 2 is where you have 160, more than 160 and more than 100. Okay, now coming on to labile hypertension. Now what is labile hypertension? This is the term which is used for someone who sometimes but does not always have their arterial blood pressure within the hypertensive range. So basically it is a borderline hypertension. Now coming on to the white coat hypertension. In this the patient usually has a normal range, but whenever they visit a doctor, the range comes in hypertension. So coming on to the accelerated hypertension, this is important. If there is a significant rise over previous hypertensive levels associated with vascular damage on fundoscopic examination without papilledema. Whereas in malignant hypertension, what we get to see is there is 140 by 99, or you can say 200 by 130 mm of Hg plus papilledema. Now coming on to the causes. What causes hypertension? There are primary factors and then there are secondary factors. In primary factors, you have factors like age, then gender, ethnic origin, diet, smoking, glucose intolerance, obesity, then alcoholism, anxiety states, evidence of end organ damage, also high renin activity. Okay, now coming on to the secondary causes usually occur as a secondary to a disease. Okay, so coming on to the secondary hypertension, so for this remember red and PCM. Okay, so for by R we have renal diseases, then endocrinal, and by D we have drugs. Then continued by P we have pregnancy. By C we have collagen vascular diseases. By M we have miscellaneous. Now coming on to the renal diseases. Renal diseases like acute or chronic glomerulonephritis, then chronic pyelonephritis, then polycystic kidney disease, renal artery stenosis. Now in endocrinal, Cushing syndrome, primary hyperaldosteronism, then primary parathyroidism, acromegaly, pheochromocytoma, myxedema. In drugs we have steroids, carboxynolone. Then we have drugs like oral contraceptives, also NSAIDs and sympathomimetic. drugs. Now in pregnancy, toxemia of pregnancy. In collagen, SLE, polyarthritis nodosa. Then in miscellaneous, coarctation of aorta and aorta arthritis. Now coming on to the pathophysiology. In pathophysiology, the etiological factors, right? So etiological factors, they produce change in the arteriolar bed. There is an increased systemic vascular resistance. Now there will be a increase in the heart rate, increase in the cardiac output, increase in the blood pressure. So there will be a decreased blood flow to organs, right? So after this, in kidney, the juxtaglomerular cells, right? They renin-angiotensin system, angiotensinogen, then angiotensin 1, then angiotensin 2. They will cause vasoconstriction, due to which there is an increase in the aldosterone secretion. Also, there is increase in the sodium and water retention, and there is increase in the peripheral resistance, due to which there is an increase in the blood pressure. Now coming on to the clinical features. So in clinical features, the general features are like lethargy, tiredness, also headache, dizziness, palpitations, right? So we draw it. First of all, in general, we have lethargy, headache, dizziness, palpitations, easy fatigability. Then are referable to the systemic vascular involvement. In this, we will write referable to systemic vascular involvement, epistaxis, hematuria, blurring of vision, transient ischemic episodes, dyspnea, angina pectoris. Now, as I told, secondary hypertension will occur secondary to a disease. So, the symptoms can be related to secondary hypertension. Those are polydipsia, polyphagia, in aldosteronism. Okay. Then there can be in Cushing syndrome, what we will see is increase in the weight, also truncal obesity, emotional liability, and so on. Now coming on to the physical signs. Now in most of the patients, there are no specific physical signs except the elevation of the blood pressure, but some non-specific which we can mention are, first of all, there might be forceful left ventricular thrust, apical heave. Then there will be loud aortic component of second heave and of the fourth. Now there can also be round faces, truncal obesity plus pink striae. In primary hypertension, what we see is when the person goes from supine into standing position, there is an decrease, there is a rise in diastolic pressure. Okay, diastolic pressure. Now in secondary hypertension, there is fall if there is absence of antihypertensive drug. Also we can see abdominal distension, left ventricular hypertrophy. Now coming on to the complications. Complications are in systems of like heart, eyes, the CNS, and kidneys. So we'll start from CNS. In CNS, what we will see is cerebral atheroma, transient ischemic attacks, stroke, hypertensive encephalopathy, subarachnoid hemorrhage. Then in retina. Now, in retina, a lot of changes occur, and we will refer to those changes by a Keek Wegener's classification. Okay. Now, this classification has four grades. Okay. So, grade 1, grade 2, grade 3, and grade 4. In the first one, what we see is there is thickening, irregularity, and tortuosity of arterioles, plus there is an increased light reflex. Now this is called as silver wiring appearance. Okay. Now in the second stage, what happens is there is constrictions. All of this plus constrictions at arterial crossings. We call it as AV nipping. Now in the third, you have a cotton wool exudate and flame shaped hemorrhages. In grade 4, you have papilloedema. Now, papilloedema is basically bulging of the optic discs with the blurred margin. Now, third organ, heart. In heart, we will see coronary artery disease, aortic dissection, aortic aneurysm formation. In kidneys, we will see that there is renal disease, proteinuria, uremia. Okay, now coming on to the investigations. Now, basic investigations which are done in all the patients is urine for protein, blood glucose, then blood glucose, then hematocrit, chest x-rays, serum potassium levels, urea levels in plasma, also ECG, then echocardiogram, then chest x-ray, then lipidogram. Okay, now which are done specifically to secondary diseases. Now, to remember this, I have a acronym which goes like PYRA. So, by P, remember plasma, renin, activity, plasma, aldosterone, activity, plasma, renin, aldosterone ratio. Okay. By I, you can remember intravenous pyelogram. Then by R, we can remember renal ultrasound or retinal angiography. Then by A, we will remember the angiography or MRI for coarctation of aorta, which was one of the miscellaneous causes of secondary hypertension. Now this is PYRA, right? Also remember PYRA 24. So 24 are urine metanephrines, VMA for pheochromocytoma. Now coming on to the treatment. There are two modalities. One is through the medical treatment and the general measures. So coming on to the general measures. So in general measures, what is first one is relief of stress. Also a very restricted diet in which there should be low sodium. Okay, there should be a decrease in the alcoholic consumption. Then exercise and quitting of smoking and alcohol, Then coming on to the drug therapy. Earlier, we had stepped sequence, but now WHO focuses on creating or tailoring the drug regimen as pertaining to the needs of the patient. So you can mention it here. So basically, the aim of the treatment is that we need to reach less than 140 by 90 mm of Hg in a normal hypertensive patient, whereas less than 130 by 80 mm of Hg in a diabetic hypertensive patient. Now the drugs that are used is, first of all, we will mention about diuretics. In diuretics, first of all, we can first of all, the what do they do? They cause sodium diuresis and volume depletion. Now, 5 milligrams of bendrofluoride or 10 milligrams or 0.5 milligrams of cyclopenthiazide. First, we will give thiazides, okay? Then we can switch on to the high potent, like more potent drugs, which are furosemide, bumetanide, torsemide. So 40 milligram, 10 milligram, 1 milligram daily. But these are not usually used because they have a short duration of action. Short duration of action. Now coming on to, we can give spironolactone 25 to 100 milligrams daily. This causes gynecomastia, hyperkalemia. Then we can give calcium channel blockers like diltiazem, verapamil. Now an important thing, we will also give the rate limiting antagonist. Okay. Then after calcium channel blockers, we can give beta blockers, but they are not given now. Metoprolol, etinolol, then alpha blockers, darazosin, darazosin. Then we can give beta plus alpha blockers like carvedilol, labetalol. Then we can also give some vasodilators like sodium nitroprusside. This is it for hypertension.